This conference will now be recorded.
Very good morning to all of you. So it's a pleasure to meet up with all of you again on a relaxed Sunday morning. So as per Professor Gauri Shankar's request and the great effort by the Stanley ENT team, we are continuing our online webinar series. And he has requested me to give a series of lectures on lateral skull-based pathology. Last week, for those of you who had joined me, you would have realized that we had discussed about all the practical aspects related to facial nerve palsy. So basically, that forms the crux of the entire lateral skull base, isn't it? So if not for the facial nerve within the temporal bone, in fact, people say that temporal bone would lose its virginity. So the only reason that other general surgeons or maxillofacial surgeons or neurosurgeons don't touch the temporal bone, and it's a pure otology specialist job, is because of the facial nerve. Because it's such a complex anatomy which runs through the temporal bone that makes it so unique. And that's the reason general surgeons don't do mastoid surgery, isn't it? Otherwise, they've already creeped into our field. They are doing head and neck. In fact, the maxillofacial surgeons have started doing flaps in the face. So obviously, it's not too far unless for the facial nerve anatomy to be in their armamentarium that people would start operating into the ear as well. And remember, among all of ear, nose, and throat, the most complex surgery that you learn, the learning curve is the highest for skull base. And either it is anterior skull base or lateral skull base. In fact, lateral skull base is much more complex and more difficult to learn than anterior skull base. Anterior skull base is all about depth perception, and also you have good tools like navigation, and you have a good eye navigation system, visual enhancement, and obviously it's teamwork along with the neurosurgeons, forehand technique, etc. But when it comes to lateral skull base surgery, it's hard work, lot of bone to drill, long hour of surgery, complex anatomy. It's tiring, and it's really pure grit, which will actually get you down to the root of the pathology. So today my talk is all focused about how we can actually approach a variety of lateral skull base pathology. I think probably about 20-30 years ago, skull base itself is out of portion, isn't it? It doesn't come into ENT. If you see a question on skull base, and probably you would think, oh, this is probably a neurosurgery question. And I don't think an ENT we would actually go there at all. You would probably refer to your enemy. So because you don't want to actually have this troublesome patient with you with all complexities. And it's a lifelong relationship. Your patient is not going to leave you, and you're going to have more problems to come back after surgery. And there was no proper systematic training in skull-based surgery as well. But over the last couple of decades, I think this particular specialty itself has evolved into a separate niche. And there is a systematic way of approaching this disease. I won't really say that this is only in the ENT foray, but there is a lot of interface. So especially where I trained in the UK, we had an interface fellowship wherein you actually work along with the neurosurgeon as a part of a team, and also get posted in maxillofacial, dental, plastic surgery, and also head and neck surgery. So eventually it's a mixture of everything that we're talking about today. So for your understanding as postgraduates, young minds today, you are the surgeons of tomorrow. This particular talk will actually give you an overview about how to actually evaluate the diseases which you would come across, and how to confidently come to a diagnosis. Primarily, if you diagnose properly, that really solves half the problem, because you know exactly what needs to be done. So it's almost like mathematics. For each pathology, there is a particular way of dealing with it, and there is a systematic approach which we should need. And also understand that this is teamwork. So you need to have a good neurosurgeon or a good maxillofacial surgeon or a plastic surgeon to help you with getting rid of the troubles which are related to the pathology. Because although it is otology which mainly forms the bread and butter of lateral skull base surgery, but all the problems related to it are nearly neurovascular, isn't it? So we need to gain good confidence to go beyond our boundaries. So today's talk as such would just give you an overview about what are the things that we are talking about. And in fact, in the future lectures, I would want to address each of the common pathologies one by one, so that you gain more knowledge, more so an exam point of view, so that you understand how confidently you can address the anatomy and also deal with the pathology, talking through the management and complications. So I'm not going to give a lecture on anatomy per se, because it's very boring, and there is very good anatomy textbooks, good YouTube videos, interactive portals, atlases, etc. So I won't really give you a basic science lecture here, because it's very boring on a Sunday morning. I would like to have this as an interactive session if some of you can actually come up with questions related to my slides, so that we can have a more fruitful interaction and understanding of the talk as we go through. So just to begin with, we all know that this is the skull base. I think most of us are really overawed by the complexity that we see here, and many of us would really not want to have this in our exams. But remember, the skull base itself has so many foramens, so many openings, isn't it? Right from the top, in the anterior lobe, the middle fossa, and in the posterior fossa as well. Now, what we are talking about is the lateral skull base today. And later on, I think probably we have a lecture on anterior skull base that we will discuss later on. But today we are talking about the extent of the lateral skull base, which starts right from the lesser wing of the sphenoid in the front and anteriorly up to the superior orbital fissure. Then you have the ROSE structure, isn't it? Foramen rotundum, foramen ovale, foramen spinosum, and we have the jugular foramen. So the extent of the lateral skull base itself is from the top, the temporal lobe, down into the infratemporal fossa, anteriorly from the lesser wing of the sphenoid and the lateral orbital bone to the posterior extent, which cuts through up to the jugular foramen. So that's all there is in lateral skull base. And the entire temporal bone, along with the adjoining suture lines, form the part of the lateral skull base. I hope that is clear for you. So all we got to address is primarily the openings in the skull base in this part of the lateral part of the temporal bone. Some of these extended lateral skull base approaches also reach up to the foramen magnum here, all the way back. Okay, these are called as a far lateral approach to the skull base. Okay, they go far back and then reach in this direction. Hope you can see my pointer. Okay, so what are all the pathologies that we are addressing here? So this includes disease within the temporal bone, or disease in front of it, above it, behind it, or below it. So essentially, we have a numerous list of structures which are available within this complex anatomy. So if you would do a good middle ear and mastoid surgery, you would limit yourself only to that, isn't it? Now, this particular discussion is about how we can go beyond a routine tympanomastoid surgery to approach structures around it. So that way, we can take out the tegment and we can go into the temporal lobe of the brain and the dura around it. We can take the sigmoid sinus, decompress it, and we can get into the sigmoid sinus. If you follow the sigmoid sinus down, you will find the jugular bulb in the floor of the middle ear. And we can dissect the styloid process and we can go down into the parapharyngeal space. So this is another approach for a parapharyngeal space from the mastoid. We can definitely dissect the facial nerve towards this stylomastoid foramen and go forward into the parotid gland, and we can do a parotidectomy. Okay, and we can go through the inner ear. These are the transcochlear and the transotic approaches, whereby we can actually get into the internal hiatus, the petrous apex, and further up into the carotid artery along the carotid canal. We also have pathology of the bulbar nerves, which are the 9, 10, 11, 12 cranial nerves. And these cranial nerves have also to be addressed in the floor of the posterior fossa. Interestingly, if you dissect further forward, like what we would normally describe as a fish type C approach, we can actually enter the nasopharynx and into the nose, beyond the clivus and the base occiput, so that we can literally get into a person's nose from the ear. Okay, so these are the different things that we can actually appreciate in our dissection. So today we have advanced technology which helps us to guide us through this complex anatomy. So we have a high definition 4K HD cameras attached to cold light source or xenolight source endoscopes. We have especially a Zeiss advanced Pentero microscope, which is the state-of-the-art currently available microscope for skull-based dissection, which gives you very high definition images with good amount of depth perception. And we also have a navigation system, isn't it? So in exam, definitely recent advances for all of you would be definitely talking about the electronic and powered instrumentation that helps us to dissect our way beyond routine in the skull base surgery. So we need to know about high definition endoscopes, angled endoscopes, light sources, power drills, and guiding systems. Okay. So these may be recent advanced questions for you in the exam, which I think you should read up, which is available easily across the internet. The other thing is radiology. Now, whenever you look into a pathology in the skull base, this is complex. So basically, you need to look carefully into the scans, and we all need to understand how best we can interpret the scans. So this needs training. So does any of you know what this is? Anybody who would want to just come back and just mention what investigation is being shown here? Feel free to talk. There is no compulsion, but if you can see this particular film on the exam or in the OSCE station, what would you say? Anybody? I think somebody was trying to answer this. Yeah. So this is a digital subtraction angiography. So basically, they have simulated the common carotid and then they have injected a dye into the arterial and the venous system. So angiography includes arteriography and venography, isn't it? So they are looking for a tumor blush. So basically, if there is a vascular tumor in the skull base, you would inject a contrast dye into the vein which is feeding it, or the artery which is feeding it, and you would be able to identify the proportion and the dimension of the lesion in the skull base. So remember that you can find more than one vascular lesion. If there is one vascular lesion, the norm is always look for more than one, because there is a chance that you may miss something else. So never plan surgery without having a thorough digital subtraction angiography and the neuroradiologist reporting it. Also, we would want to look at two things. When you want to find the main feeder, always look for collateral. Okay, so there is an external carotid or internal carotid feeding it. Always look for a vertebro-basal system, which may also be collaterally feeding it. So even if you embolize this part of the vasculature, you may still have collateral bleeding from the vertebral system. And also, it's important to look at the contralateral side. So whenever you have disease on one side, and suppose you need to sacrifice it on table, always make sure collateral supply is important. So if the collateral system is good enough to counter the rest of the normal tissues, the bleeding will be more, but at the same time, the healing will be better. And also, even if you ligate this diseased part of the tissue, then you may not have any neurovascular accidents. There won't be any CVA or stroke. So, but has the advances like this in imaging made us more conservative and less radical? Certainly, yes. So previously we had very rhomboid surgeons who could literally take 1/3 of the skull out in case of extensive disease like skull base cancer or huge glomuses. But nowadays we are becoming less and less morbid. We are making our surgery more precise, focused to the point where the disease is, trying to prevent collateral damage. So we want to preserve the neurovascular integrity of the lower cranial nerves. And that's why today DWI imaging, and I'm sure all of you would have heard about how to do surveillance imaging for cholesteatoma. So in cholesteatoma, we would want to see if there is any residue or recurrence by doing a diffusion weighted imaging, what is non-echoplanar imaging. Okay, non-echoplanar diffusion weighted imaging, MRI, which will pick up any residual cholesteatoma as small as 2 millimeter. That really helps us to make sure that this person is probably not going to require a second look mastectomy, or there is a need for the patient to be re-explored even before the cholesteatoma becomes bigger. Similarly, tiny intracanalicular acoustic neuromas in the internal meatus. Nowadays, if you do 100 scans, we are able to pick up about 5 to 6 patients who are having small lesions within the IAM. These lesions do not need to be treated at all because they are incidentally picked up. Unless and until a patient has got asymmetrical hearing loss or inadvertently some facial palsy or vertigo symptoms occur, we do not want to address these lesions. But these are incidental lesions. Many times you would have asked for an MRI of the IAM, and then the neuroradiologist will give you a report saying there is a vascular loop kinking on the 8th nerve, and immediately you will say neurosurgery opinion. But essentially, look at the patient. Is the patient having any trouble? So that is how the patient has been since birth, isn't it? So eventually, that is the reason why we are more focused on identifying tiny lesions. And today, embolization has become a very major part of skull-base surgery. So, in fact, radiologists, interventional radiologists have also become part of skull-base surgery. I hope that gives you a clarification about how we approach skull-base surgery today differently from what it used to be about 2 decades ago. Any questions, please feel free to ask in between. If I am fast, I will slow down. Okay, so we have looked at the patient, we have assessed his clinical condition, we have also done imaging. Now we have to plan surgery. I'm not going into the basic clinical assessment, okay, but that I'll do when we take up the individual pathologies. So this is an overview of the different approaches to diseases in the lateral skull base. So as I previously mentioned, we can get into the lesion because the most important part of surgery itself is actually reaching the pathology. Many of these pathologies are deep inside, isn't it? So we have to dissect a lot to get in there. And the problem is by the time you do that, you're tired. And when you actually reach the main part of the surgery where the disease is, your mind is not fresh. And it's a long day and everyone else is really urging to go home. So basically that is the point where we need to be very careful, make sure that we can get the disease out with less amount of morbidity. So how do we best address this? So these are the different approaches. Again, in the exams, suppose they ask you, there is an acoustic neuroma, how can you reach it? Easy questions are, there are 3 routes. One is from the top. From the top, you actually go through a middle course approach. One is from behind, what we call as the retrosigmoid approach. And the third one is the routine translabyrinthine approach. The only other couple of things that I need to highlight here is there are sub-classification of the transtemporal approaches. In fact, I have another lecture on transtemporal approaches, which I'll do where I would explain in detail about each of these approaches. Now, basically, it's all about the inner ear. Now, when you're going through the temporal bone, through the inner ear, getting to the lesion, we can either go behind the labyrinth, which is retrolabyrinthine, or you can go through the labyrinth, which is the translabyrinthine, or if you can go take down the cochlea and the labyrinth together, then there are 2 different ways in which you can approach this. If you leave the facial nerve in between the cochlea and the labyrinth, and if you can dissect around it, then that is becoming a trans-otic approach. You're taking down the otic capsule. But if you reroute the facial nerve away, or if you can dissect and sacrifice the facial nerve, get it straight to the petrous apex, then it becomes a transcochlear approach. So remember, the transcochlear approach is the largest lateral skull base approach which is available. Okay, so I hope that is clear. But from the skull base surgeon's perspective, we have something called as a surgical highway. Okay, so this is the surgical highway which we all have to follow, and this is helped through navigation system nowadays as well. So all surgeons will pretty much start off from behind, decompress the sigmoid sinus, expose the posterior fossa dura. They will go down the jugular bulb. So this is the jugular bulb that you can see. Then they will follow the jugular bulb anteriorly into the carotid jugular spine. So this bulge is actually carotid canal. So once you get the disease out of the carotid canal, and laterally you will have the TM joint and the eustachian tube, and those things can all be removed. So why is it called as a highway? Because every structure that is medial to it is very important, and the entire dissection is through following the carotid artery. So, and anteriorly, once you get past the carotid artery climbs intracranially upwards into the circle of Willis, and you can just further forward dissect up to the trigeminal region, and you can reach the infratemporal fossa, pterygopalatine fossa, and if you go down, you get into the clivus, you will get the orbital fissures, and the only thing that you need to sacrifice in this anterior aspect would be the mandibular nerve and the middle meningeal vessel. Okay, there are only 2 important structures which will prevent an ear surgeon from getting into the nose. Okay, the middle meningeal vessel going lateral to the internal carotid artery, and you have the mandibular nerve. So no harm in sacrificing both of that if you need to reach into the petrous apex following the carotid artery forward. So that is called as a surgical highway. And that's just for your knowledge. Okay, and so again, getting to the petrous apex, there is a lot of confusion about how we can actually do a transtemporal approach to the petrous apex. Now, this is again an exam question. I'm sure I think Professor Gaurav Shankar will be very happy to ask quiz regarding the names of these different approaches. He's always excited about the names, but in general, for us to easily understand the approaches, Again, as I said, in front there is cochlea, behind there is labyrinth, right in the middle is the facial nerve. So we can actually go above it, go behind it, go below it, or go in front of it, or go anterior to it, right in front or very far anterior to it. So the divisions of these approaches are based upon anteriorly the ankle carotid artery. In the middle there is a facial nerve, and behind there is a sigmoid sinus. So there is an artery in front, there is a nerve in the middle, and the sigmoid sinus behind. So the hearing apparatus of the cochlea is between the artery and the nerve, and the balance system of the body is the labyrinth, is behind the facial nerve and the vein. So if you have that concept in mind, so the names are only for the exam purpose, but nowadays the nomenclature has been removed because further refinement in the techniques have appeared. So if you go through the superior subsacral canal opening, there is a subarcuate artery, which is a branch of the anterior inferior cerebellar artery. So that is called Franklin approach. Okay, if you go above the labyrinth, taking out the antic tegment, it is called Thornwall approach. Okay, if you go behind the labyrinth, that's a retrolabyrinthine approach. You can go below the facial nerve, retrofacial, beneath the facial nerve, and go below the cochlea. That is another approach, is a retrofacial approach. And Jar-Stoffer, again the same famous person who classified the ossicular anomalies in the middle ear, congenital anomalies of the ossicles. Jar-Stoffer classification. Remember that, again that is another exam question. This is the hypotympanic approach. Okay, if you go in between the cochlea and the carotid, then that is the Lempert-Ramadier approach. There are a few other approaches in newer textbooks, but I won't really insist on the names, but please know the different approaches. I hope that picture is clear. Right, but there is a no man's land. What is a no man's land? Where nobody wants to touch, isn't it? So it is not a neurosurgeon's property, it is not a maxillofacial surgeon's or an ENT surgeon's property. So that area, that into mark, is not a pure otological site. Why? Because I'm not talking about the surface of the masthead, I'm talking about the petrous apex, the depth. Because there is the connection between where you have integration between the orbital apex, you have the petrous apex, you have the connection of the anterior and the middle skull base, and you also have the connection of the attachment of the pterygoid plate and the maxilla. Okay, so that's critically area where you are arriving deep down into the petrous apex, where all the different structures connect together. So basically, this is no specialist site. This is an interface site where everybody has got their own part to play. Mostly neurosurgeons manage this. Real neurosurgeons who are actually approaching this from above manage this. Honestly, total petrosectomy is not possible in human life. The maximum that we can do is take down the inner ear and reach towards the petrous apex, even in case of petrous apicitis or Grandin-Egos syndrome. I'm sure you must have all heard of it. We can't really go and reach into the petrous apex. Why? Because the superior and inferior petrosal sinuses connect here into the cavernous sinus. Now, you cannot physically or surgically remove the petrous apex totally, unless there is a disease there expanding the whole area. If there is a petrous apex meningioma, you can debulk it. Okay, but I don't think surgically it is possible to take it out, and the patient cannot be alive. Okay, so we most likely end up with a subtotal petrosectomy. So that is the area which is critically called as a no man's land. Okay, so again, I think just to wake you up, another question: if somebody can read the scan, it will be nice to see if we can diagnose this scan. There is a pathology here. Can somebody be brave enough to come in and give me an answer? No punishment, nothing. Please do ask me any questions. Feel free to actually interact. Can anybody see this pathology here in this scan? First of all, exam going. What can you describe the scan first? What kind of scan is it? Anybody would like to give me a feedback? I hope you're all listening. Okay, Sangameshwaran.
Sir,
What type of scan is this?
it's a T1 weighted MRI scan, sir. It appears so. If I'm wrong, I'm sorry, sir.
Okay, you said it's an MRI scan. That's right. Why is it T1 weighted?
CSF appears black, sir. No, sir.
But
CSF.
come on, then I think you should change your set.
Yes, sir. T2 weighted MRI, sir.
Correct. So which side is the pathology, right side or left side? So this is the right, that's the left.
Pathology is in the left side, sir.
Okay. Left side, do you think this is it?
I'm not sure, sir.
Okay, that's what makes it interesting, isn't it? So anybody else who has got a difference of opinion, feel free to just come up and then answer. There's no restriction.
Swati ma'am has texted it as
Left.
intra-acoustic meatus, acoustic neuroma on left side, sir.
Right. So the diagnosis is correct, but the side is wrong. Okay. So let me just explain that to you. So how do you look at the IAM? And that's what I wanted you to understand from this scan. Always look into the IAM in two different aspects. One is look for the dark shadow on a T2 weighted image. So basically whatever white you are seeing here is all CSF. Okay. So you can see the CSF here in the medulla. You can actually see the cistern which is filled up with the CSF. All the round dark structures are the blood vessels. Okay, and can you see the nerve on the left side? There are two nerves coming up on the left side in the CP ankle. So this is a 7th and 8th nerve, okay, complex on the right side. Okay, and similarly, this side is not very clear, but there is some kind of a dark shadow which you would see here. Okay, and that is what makes people think, okay, there is a lesion here, there is a tumor here. I'm sure you can all appreciate the cochlear aperture, and then the labyrinth here. Okay, similarly, you can see the cochlea and you can see the labyrinth here. Okay, so when you see this, don't stop there. An intelligent student will ask, sir, can I have a T1 weighted MRI scan with gadolinium enhancement? Okay, always ask for a gadolinium enhanced, contrast enhanced, T1 weighted image. Only in T1 you can actually do a gadolinium enhancement. And that the internal meatus will enlighten. Actually, it will highlight the tumor. So actually the tumor is hidden. So basically the tumor is here. So this is a small intracanaliclar tumor on the right side, less than 1 centimeter, which is restricted itself within the porous acoustic. It does not actually come into the CSF system. Okay. So what is this then? This is actually a vascular loop. So this patient has got a double pathology. The right side there is an incidental internodontal meatus. This patient came to me with a left-sided pulsatile tinnitus. Okay, so basically there was a pulsatile tinnitus with high frequency hearing loss on the left side for this patient. On incidental imaging, this actually picked up the acoustic neuroma on the contralateral side. Isn't that interesting? So what do we do now? What do we tell the patient? So if you find one pathology, you find another one. So you have got to deal with both the symptomatic vascular loop and the asymptomatic acoustic. So I counsel the patient with regards to all conservative measures that we can offer for conservative management of the vascular loop. The only way that we can actually take the vascular loop symptom out is by a microvascular decompression of the IAM, which the neurosurgeons will do. Because the inner ear is absolutely normal except for high frequency loss. So from whatever transtemporal approach, we cannot do anything for the vascular loop. Okay, and for this, if you find an incidental small lesion there which is not causing any trouble, leave it alone. Okay? Do not do any harm. That is the Hippocrates code. So what we would suggest to the patient is, we just say this is a benign lesion on the right IAM, incidental finding. There is no problem related to this, no hearing loss. You have to do an annual MRI once a year. Just follow this up. If you follow this tumor over a period of, this may have been there for many years. If you follow this tumor for a period of 5 years and there is no change, leave it alone. It may never grow. Maybe it's like scar tissue. Only about 40% of these lesions will grow by more than 2 millimeter per year. So by the time the patient actually comes back with a symptomatic tumor, patient will be literally very old or dead. Okay. So is that clear how to manage this patient? I hope any contradictory thoughts, please do come. It will be interesting for us to discuss. So we'll move on. So the other important thing is in exam, if they put scans like what we had, in fact, this scan also was confusing, isn't it? So we could not get a diagnosis. How to give a differential diagnosis for a lesion in the CPI? Okay, so it's very simple way, easy ways of finding that out. So I will just show you a series of images and tell you how to diagnose differentially the various lesions that we would expect in a CT angle. So in an exam, if any scan comes up with a lesion in the inferior meatus, don't only think about acoustic neuroma, because acoustic neuroma is only one among the lesions. There are differential diagnoses. So it includes meningiomas. We also have epidermoid cysts. I'll come to all these things later on in the other images. But this one, are you all convinced that this is a meningioma? This lesion? Yes or no? So yeah, it's very clear because see there is a broad-based tail. The dural meninges is actually tethered to the lesion. There's a large meningioma which is broad-based. Okay, it's a broad dural base, and it is eccentric to the IN. It is not like a mushroom on the IN. It's eccentric. It's on a different plane. Okay, and there will be erosion of bone. So meningiomas are very strongly bone eroding property. They have bone osteoclastic property. So they start eroding the bone. So they'll start thinning out the petrous bone. Okay, and they also cause large indentation into the brainstem and the cerebellum. So this is a large meningioma. It is broad base. There will be a dural trail, and the CSF will be constricted around it, and there will be erosion of the bone. These are the features of a meningioma. How about this one? It looks like a meningioma, isn't it? But how to differentiate? This is an epidermoid cyst. Epidermoid cyst is nothing but a cholesteatoma, which is intracranial. So ENT surgeons call this cholesteatoma, but neurosurgeons call the same as epidermoid cyst. Epidermoid cyst, how do you differentiate from meningioma? You have to do a non-EPI, what I had mentioned before. It will be a MRI diffusion weighted image, a non-EPI scanning will give you very clear imaging, which will differentiate between an epidermoid cyst and a meningioma. Again, this will cause bone destruction. This will also cause blockage of the CSF cistern. But what is interesting is it will be low signal on T1. This is T1, and there will be high signal on T2. Why? Because there is fluid retention within the planes of the cholesteatoma. So there is central necrosis in the cholesteatoma sac, surrounding which there is enzymatic activity. So there is a lot of inflammation, inflammatory markers surrounding the disease. So that will be enhanced on T2. Okay. But in meningioma, you won't have that. Is that clear? I hope that there is a clear differentiation between meningioma and epidermoid cyst. Cholesterol cyst. Okay, so interestingly, cholesterol cyst is enhancing both on T1 and T2. Okay, so in cholesteatoma, you will have low intensity on T1, enhancement in T2. But cholesterol cyst will have enhancement. Why? Because there is high intensity of organized cholesterol material with fluid restriction within the tumor space. Can you see that this cholesterol cyst is actually gone anterior to the petrous apex, and it is encasing the cavernous sinus and in the hypocellular area in front of the brainstem. This is the basilar artery. Can you see the right carotid artery and the left carotid artery? It's sitting right in between the major vessels in the base of the skull. It will be enhancing on both T1 and T2. Okay, it is identical to epidermoid cyst, but it will be highly enhancing on both. Okay, moving on. Arachnoid cyst. Arachnoid cyst is nothing but a fluid filled with CSF, isn't it? So if you do a CSF flare imaging, which will be specifically looking for the CSF flow pattern in the skull base, you will pick it up. Remember that this is actually an acoustic neuroma. You can all see this lesion here. There is an acoustic neuroma with necrosis and CSF collection. So 10% of acoustic neuromas can actually be misdiagnosed as arachnoid cyst. And in fact, 10% of the acoustic neuromas will be cystic, which contains cystic CSF fluid spaces. So, and these are the 10% of acoustic neuromas which can actually hemorrhage, and they have poor prognosis because they can suddenly hemorrhage, causing obstructive hydrocephalus. The patient can end up with a stroke and intracranial hypertension. So these are the cases who will also require a simultaneous shunting of the CSF drainage system along with tumor. Okay, that's an arachnoid cyst. Moving on. So lipomas. Okay, you can actually find a small high intensity lesion and then immediately we'll have a panic about that's a great tumor in the brain. But essentially this may just be degenerated fat because meninges have a lot of fat because the brain is continuously pulsating. The fats gets displaced. Okay, and then they get reorganized. So it's just a scar tissue. How to identify fat on a brain scan? Very easy. So basically, you have to do fat suppression MRI. If you suppress the fat on an MRI, it will disappear. The tumor will disappear. Okay, the next moving on. Facial schwannoma. I think we talked about this in the last class. But a large facial schwannoma will very classically present in the labyrinthine segment of the facial. So it may also enter into the internal rhinitis, but predominantly this will be sitting in the anterior aspect of the labyrinth. So if you carefully look into that area of the labyrinth or the inner ear of the optic capsule, you will see that lesion very classic. Also clinically, a patient who's got a retrocochlear pathology, if he comes with facial palsy, unless proved otherwise, you have to take this as a facial lesion, facial nerve lesion rather than a vestibular lesion. Okay. So think of facial schwannoma or meningioma rather than an acoustic nerve. And moving on to the rest of the lower cranial nerves. Remember, the seventh nerve and the eighth nerve is not only the nerves which can cause tumors, but we have other cranial nerve schwannoma. So if we have a dumbbell-shaped tumor, this is possibly coming from the jugular foramen. So you can actually see the lesion coming down the jugular foramen extracranially and also extending upwards superiorly to form a dumbbell-shaped lesion across the jugular foramen. So that is classically a lower cranial nerve, jugular schwannoma. So what is this? So I actually covered all the different lesions in the skull base, all the benign lesions. Can somebody come up to say what kind of a lesion this is? So this is the skull base here. You can actually see the temporal lobe. You can see the cerebellum. This is the CP angle. There is a tentorium cerebelli, which suggests that this is the upper part of the CP angle. So this is a junction between the temporal lobe and the posterior middle fossa and the posterior fossa. Temporo-occipital brain will be here, and below that will be the cerebellum. And this is the orbital apex. You can actually see the sphenoid sinus. You can see the cavernous here, and you have the carotid canal on either side of the cavernous sinus. So this is a lesion which is going partly into the middle fossa temporal lobe, also extending into the brainstem, extending into the cerebellum, sitting behind the orbital apex, lateral to the cavernous sinus, at the upper part of the CP angle. So I've given so much clue. Anybody? So I had said that there are other nerves which can cause schwannomas. Okay, so this is actually a trigeminal nerve schwannoma. So this is arising from the Meckel's cave. So this is a tumor on the left Meckel's cave arising on the anterior aspect of the CP angle, medial to the petrous apex, enhancing up into the middle fossa and the posterior fossa. Okay, so again, this can also be approached from lateral skull base approach. Okay, if you see more than one tumor, always think of NF2. Okay, NF2 means two tumors. So you can actually find that there is a gadolinium enhanced T1 weighted MRI with a large tumor compressing on the brainstem on either side. So this is bilateral NF2. Okay, neurofibromatosis type 2. If you find such tumors in the brain, that means that there is more than one tumor. You may find a schwannoma along with a meningioma or a cavernoma or a glioblastoma. If you find such kind of a combination, always scan the spine. Okay, always also look for an MRI of the cervical spine all the way down to the thoracic and the lumbar spine also. Why? Because you can actually find another indentation here. So that is a small spinal meningioma. So NF2 patients will always have more than 2 or 3 lesions, and you have to address all of them together. Right. So finally, what are the other lesions that can happen in the lateral skull base? Always think about vascular lesions, and the commonest among them is the glomus tumor. I'll show you some pictures of that. But we can also have abnormal dilatation and tortuosity of the great vessels as they enter into the skull base. So commonest among them, what we could actually see in many of our scans, as I had mentioned before, is the ICA loop. Okay, the ICA loop is a blood vessel which can kink on the 8th nerve complex, causing symptoms of pulsatile tinnitus, vertigo, and middle ear spasm. Muscle can, tensor tympani muscle and the stapedius muscle can go into spasm. Middle ear myoclonus. Okay, you can also have AV malformations, giant aneurysms in the CP angle. Those things will cause what we call as a tic dolorum. Does anybody know what is a tic dolorum? Which is very similar to hemifacial spasm. Okay, the muscles will involuntarily contract. So the face will go into a grimace. You would have seen some patients coming with winking their eyes and then grimacing and frowning at you. And we can also find vascular lesions. So some of these meningiomas and schwannomas or hemangiomas are very vascular. They bleed a lot. So you have to arrange adequate blood and also have a neurovascular surgeon stand by if suppose there is a lot of bleeding in the skull base. And I will show you some pictures of glomus as well. Now, each of these conditions we will discuss further details as in further classes. We will look into each of these pathologies with regards to their management. Now, what is HELPS syndrome? Does anybody know? Again, as probably a quiz question. HELPS, again related to the same pathology, which is hemi-esophago-laryngo-pharyngo spasm syndrome. Okay, that's again for a quiz or maybe in biology. HELPS is hemi-esophago-laryngo-pharyngo spasm syndrome. So, which means that all the lower cranial nerves, okay, starting up 9, 10, 11, 12, into hyperexcitability because of tumor compression. Okay, so the entire half of the larynx, esophagus, everything goes into spasm. Right, glomus tumors, again there is a separate class on this, but we have to understand that if you find one glomus tumor, always look for more than one. So nowadays we are finding a lot of combination of these. We are having glomus tympanicum, which is restricted to the middle cleft. You can have a tumor going down at the jugular fossa, which is the tympanojugulare. Some of these lesions will also have a incidental carotid body tumor in the carotid bifurcation. They may also have a glomus vagale. So in fact, we had operated on a glomus tympanojugulovagale in a workshop a couple of years ago. Fortunately, a patient is doing fine, but a facial nerve had to be sacrificed because we were dealing with such a huge tumor. It's been about 2.5 years now when we are following this patient regularly. But this patient is eventually ended up with what we call as a HELPS syndrome because of all the nerves, low cranial nerves being compromised in the vicinity of such a big tumor. Most of the tumor was debugged and we had to give post-op radiotherapy. The patient is still alive. So that's the only advantage of having done such a huge morbid surgery. Otherwise, the compression would have actually killed the patient and she would have been having a stroke and then. Okay, so a small tumor, this is easy, isn't it? Can you see this picture? Can you describe what this sign is? Anybody? Yes.
Rising sun sign, sir.
Right. So this is a rising sun sign, basically. So what are the other signs related to this particular otoscopic picture? What is brown sign? If you seagullize this particular otoscopic picture, there will be blanching of the blood vessels, isn't it? Because it's a vascular tumor. Okay, so the blanching of the blood vessels on seagulization of the ear canal or pneumatic otoscopy or brown sign. Okay, so that's interesting. Right, so huge tumors, again, I've already mentioned the sign here. What is that? This is the angiographic image of a splaying of the carotid at the junction where the common carotid divides into internal and external because of tumor sitting in between. Okay, so this is Lyer's sign. Okay, Lyer's sign is again an angiographic sign, digital subtraction angiographic sign. So again, that's another exam question. So, and I had already talked to you about embolization. Now, embolization not only identifies a feeding vessel to block the vessel, but we also find the collaterals. That's very important. Now, embolization also will tell you whether a patient's tumor is so vascular that it cannot be operated. So, we can make a conclusion of whether we can approach this disease and get the tumor out, or whether the patient is inoperable. And sometimes they will do what we call as an end-point embolization. End-point meaning that the patient's longevity is palliative therapy. So, patient's tumor is embolized in such a way that there will be some temporary release from the patient's symptoms until the collaterals will start forming. And you have to continually keep embolizing the tumor to keep the patient pain-free and also to reduce the amount of low cranial nerve morbidity that the patient may have because the tumor is inoperable. Okay, so whenever we do such morbid surgery, it is always important for us to clearly sit with the patient. This is not something that we can routinely do like a mastoid surgery consent. We have to explain the severity of the disease and the surgical approach. What are the important structures in the way? What kind of complications can happen with regards to injury to the cranial nerves, whether we are going to preserve the inner ear or destroy the inner ear, whether the patient will lose the hearing, balance, facial motor function. Is there going to be any CSF leak which we need to manage? Is there any vascular injury which requires further treatment? Post-operative ICU care, neuro monitoring, the risk of tumor regrowth, etc. And most of all, we have to take a very high risk consent. And sometimes in the Western practice, in my fellowship in the UK, there was a special form which said if you agree to undergo the surgery, the outcome may not be limited to death, which is very interesting. So sometimes it is better that the patient dies on table, is it? Or patient dies because of the disease, because once you touch the patient, the morbidity of the disease can get worse, and the patient may end up like a comatose patient, like a vegetable, with probably injury to the brainstem, isn't it? The patient needs to be on ventilator, and he may not have regained consciousness. So that is even worse than dying. So that's the reason why this is special comment on not limited to death. And only when that is taken, then we have no medical legal liability on touching that patient to do such a big operation. Okay, so almost I think different approaches have been highlighted to the lateral skull base. I've also indicated the differential diagnosis between the various pathologies that we are going to talk about in the next few classes. So I think I will just show you a few case scenarios, and then we can have a further question and answer session. I think it's about half an hour done already, but maybe another 15 minutes maximum, and then we can, feel free to ask questions today, because that is a way that we can actually see whether you need to improve a talk, whether some things have to be addressed more in detail, whether I need to slow down, go further down to basic level, etc. So don't feel inhibited by the questions, and there is no right or wrong answer, but we can always learn from each other. Okay, so, and please do ask your questions on the chat box. Sangameshwaran can ask them to me. Okay, so this is a case scenario where you have a picture of a patient, a young man with a moderate sized CP angle tumor. The fortunate or unfortunate thing is the patient has got good hearing. Okay, so basically you can't do a transplant because you're going to take down the inner ear to get to this, the hearing will go. Okay, patient has got vertigo, and interestingly, trigeminal symptoms, which means the tumor is going up on the upper end of the CP angle, compressing on the Meckel scale. Okay, there is no obstruction, no hydrocephalus, and the sad thing is patient's facial motor function is normal, isn't it? It's a very complex scenario where inner ear is normal, facial nerve is normal, no obstructive hydrocephalus, but patient is having vertigo and a big tumor which has to be treated. What is the best option? Anybody who would suggest what approach? I've talked about the different approaches, or this is all about rational management to this lesion. Any ideas? Anybody? What is the best option that we can give this patient? Yes, very good. I got two answers already. One is Bedel-Fossa approach. Certainly, yes, because this tumor can be easily reached from the top. More so importantly, because the patient has trigeminal symptoms. Because trigeminal nerve is in the upper end of the acoustic neuron. So if you want to go up there, the best approach is to go from above rather than from behind. From behind, you have to retract the cerebellum a lot to actually reach this. Can you see all this is normal cerebellum? Okay, going suboccipital or retrosigmoid is a lot of tumor dissection. So that means that cerebellum will swell, and the patient can have cerebellar symptoms post-surgery. So easiest is from the top, Bedel-Fossa approach. Also because the tumor is on the cranial aspect of the CT angle. That way you also preserve the facial nerve. I'm not sure whether the facial motor function will be preserved, because when you take the tumor out, some few facial nerve fibers also will get injured. But predominantly the tumor can be easily addressed from that aspect. Okay. I hope that is clear. So we'll move on to the next case scenario. So this is a patient who has had a skull base fracture. Okay, it is an otic capsule sparing fracture. So fortunately the cochlea is preserved, so hearing is okay. But patient has got conductive loss because of CSF in the middle ear and in the mastoid system. You can see the fracture line through the upper end of the attic region of the temporomastoid bone. The only thing here is the facial palsy. Okay, patient has got a total facial palsy. Okay, and ossicles are intact. As you can see, the attic cone is preserved. What would you do? Anybody who has a suggestion for approaching this disease? So remember, the inner ear is intact. Okay, CSF is in the middle ear. Ossicles are intact. Patient's got conductive hearing loss, but facial palsy needs to be addressed. So there is a fracture through the facial nerve. Middle fossa, correct. So very good. I think slowly, I think my classes are making sense to you. Good. So middle fossa is the right thing. So again, see, why should you destroy the middle ear and get it to cause the patient to have more conductive loss? Because you reach this place behind the ossicles in the attic, you have to remove the ossicles, isn't it? So ossicles are intact, so don't touch. So the problem is the fracture line is above the attic, so the tegmen is the issue. So middle fossa will actually take you directly down this fracture line. All you need to do is take out the bony spicule, which is pinking on the labyrinthine fascia, and probably graft it, seal the CSF leak, do a tegmen repair, and that's it. So simple. Good, next scenario. So this is a patient, in fact, we had a couple of years ago with bilateral skull base fracture. One side, the fracture had actually gone through the OT capsule. So this side, the patient has got a dead ear. The other side, it's a OT capsule, which is sparing, sparing OT capsule, sparing fracture. So this side, there's an attic bone, but you can actually see that the fracture has gone through the labyrinth, but preserved the cochlea. So one side, the patient has had residual hearing, the other side has got a dead ear. And the right side, facial nerve was injured because it was going through the attic region, sparing the inner ear. On the left side, the fracture had gone through the cochlea, so the facial nerve got preserved. Okay, but you can actually see that there is CSF leak on both sides of the fracture. The right side is more predominant than the left side. So, what approach would you suggest for the right side? What approach for the left side? Anybody? You can't do bilateral surgery in the same sitting, so we had to stage it one after another. The right side was worse with the CSF otorhinuria. You can actually see the sphenoid is also filled with CSF. Somebody said right side middle fossa, some other person has said translab on the right. Okay, so again reiterating the fact, patient's inner ear is preserved, hearing is preserved. If you go translab, patient will lose the hearing on the right side. Okay, you have to save the facial palsy, you have to repair the CSF leak on the right side. So option is either transmastoid, remove the ossicles, repair the ossicles, and you can do a tympanoplasty, decompress the facial nerve onto the labyrinthine segment, leave the inner ear alone, and seal the CSF leak and come up. Or you can go a middle fossa, as somebody said, you can go from above, follow the fracture line. It's easy in fracture cases because you just have to find the fracture plate and then follow it as it goes forward. Okay, so seal that labyrinthine injury. Okay, leave the cochlea alone. Try to preserve as much of the inner ear as possible. Seal the tegment from above. On the left side, it's easy, isn't it? It's a dead ear. So all you need to do is facial nerve decompression. You can do a complete translab, follow the fracture line. You can even take a cochlea out, find the facial nerve, decompress it right from the first genu down to the stylomastoid. Then you can do a blind sac and come up. This is a dead ear, so you don't have nothing to save. So if you do a blind sac itself, the CSF leak will get arrested. Is that clear? Good. Moving on. So this is, I think when I came back from the UK, this was my first case. Young lady, 18-year-old college student, who actually was managed elsewhere. Many times she got admitted in an ICU with the diagnosis of tuberculous meningitis. Okay. And she had history of tuberculosis, which was treated with ATT, but after that there was a relapse of meningitis, and then they had suspected recurrent tubercular meningitis, and they had treated her. Incidentally, the CT scan, MRI, everything showed that there is CSF collecting within the mid-ear cleft. And also interestingly, the patient had a cochleo-vestibular dysplasia on the left, in the same side as the disease. Right side is absolutely normal. So the patient had no hearing from childhood in the left ear because of the cochleo-vestibular dysplasia. They never can actually. Basically, this was an incidental finding about a dysplasia. And looking at this scan, some other ENT surgeon has actually opened up the patient, thinking that possibly this was CSOM. cholesteatoma extensive going into the IAM dead ear. They did not really intricately look into the dysplasia aspect of it, and the patient had a mastoid. During the surgery, there was CSF leak. Immediately, the surgeon panicked and then sealed the CSF leak site on the, because it's a dead ear, isn't it? So you just seal this with bone wax, and then they put a graft, and then patient was treated with already patient in ICU or meningitis. They continued on IV antibiotics. She recovered. Eventually, she got better. But about 1 month later, she had another bout of meningitis. Okay. And then immediately she was referred to us. So doing a cysternography, this is a complex case. Okay. There is a background of malaria malformation. Patients had history of tuberculosis meningitis, treated, again had surgery, and then after that there was a messed up complication. Patient developed a further bout of seizures, and then she was transferred on to us. What we could find was on an MRI cysternography, there was a suspected leak on the labyrinthine windows. Okay, and patient also developed facial palsy after surgery. That's another thing, because of the dehiscence of the labyrinthine part of the facial nerve, which was milled during the surgery. So complex scenario. So as far as I probably was more experienced with skull base than I was now, but so we took it up and we re-explored the situation. So we went radical this time because the patient had dead ear in this side, so you don't need to worry about integrating, preserving the structure. The facial nerve also is already there, so nothing to preserve. So we do pretty much a trans-otic approach. So we left the facial nerve in its normal anatomical pathway. We took down the cochlea, took down the labyrinth, followed the CSF leak from the crevices of the well-limitized. As you can see, it's a very well-limitized mastoid. So we took out everything, made it into a single cavity, and then approached towards the petrous apex. Then we can actually see where the CSF leak was coming from the IPM. Sealed it up, multi-layered closure, muscle, fascia, tissue glue, fat, and everything. And decompress the facial nerve, as we had exactly talked about before. Okay, and we have to have a complete water seal closure. Because why? Because patient is having recurrent bouts of meningitis. And when you actually open up these areas and leave any crevice to cause further infection, this will again cause meningitis. So we had to seal the eustachian tube and then do a blind sac closure and close up the flap with a rotation temporoparietal flap. I'll show you a picture of a temporoparietal flap also. So this way we have completely secured the entire temporal bone from infection. We have sealed up the entire cavity. We have not allowed the CSF to leak out anywhere. Multi-layered packing and closure, sealed up. The problem was the bone wax. The bone wax had desiccated, degenerated, and it actually found its way into the IAM from the cochlear aperture. Okay, where they had plucked the cochlea and the middle ear. This bone wax had caused chemical meningitis. Fortunately, this time patient did not have infected meningitis. The CSF tap was normal. But that's the learning point. Never use bone wax to seal the inner ear. Okay? If you have CSF, don't put bone wax on. A very interesting case. Now, patient has been under follow-up with me for the last 3.5 years. She's doing fine. She's got back to college, and she's back to her education. Almost she was near dead when she came to us. Right. So I think this is one more case. Again, very simple, isn't it? So what is this situation where your brain is herniating into the ear? There's a soft tissue shadow. As you can see, this is the tegmen, isn't it? So from there, you can actually see that the brain is herniating into the ear, where there is a large defect in the roof of the tegmen. The brain is actually in the middle ear. The whole bone is eroded. So this is a situation where we call this as a fungus cerebri, which is complete herniation of the brain into the ear. But this part of the brain is part of the temporal lobe is dead. Okay? It has no function. Whenever the brain herniates out of the cranial cavity, it loses its function. Okay, or just cauterize it and close it up without any space of leaking. So only thing is, because of the cholesteatoma, this patient has had an old patient who has had diabetes, skull base osteomyelitis, multiple cholesteatoma surgeries, ending up with a herniation of the brain because of the large erosion defect which has caused the brain to come into the ear. Again, same procedure. Treating such radical cases is easier than you think. Never get scared about big diagnosis on the scans. Okay, the thing is here, you can't be conservative. You have to be radical. So for all patients with similar scenario, make a thorough job. Get as much of disease out of the way, and always completely seal it up. in all the nooks and corners. Do a blind side, seal the excision tube, do a radical mastectomy, and the patient will be fine. And of course, post-op surveillance with imaging is very important. Okay, and the worst case scenario for us is basically temporal bone cancer, because in cancer we don't have any limitations. So, for example, in this scan, you can actually see that this patient has got a cancer which is going into the cerebellum, isn't it? So this is a transtemporal cancer going into the intracranial cranial cavity, the posterior fossa. How much of the cerebellum can you excise? Nothing, because you can't see. Can you see that? The tumor going into the cerebellum. So eventually, this kind of a scenario, the complexity of the surgery is high, and the morbidity related to the surgery is also very high. The patient will definitely have meningitis, stroke, loss of memory, multiple cranial neuropathies, imbalance, etc. So this becomes palliative. So should we touch this patient? I still have doubt. Any alternative answers? Most welcome, so we can discuss such cases. Advanced cancer. Okay, so finally, osteomyelitis. Again, this is the nemesis of skull-base surgery, as we would say, because osteomyelitic bone, there is no limit to this. It is there in all the different directions. So osteomyelitic bone, especially in a patient who's had diabetes, who's developed osteomyelitis, unfortunately develops cancer, has had radiotherapy for cancer, will eventually end up with a temporal bone which will slough out. Okay, so you will end up with an osteomyelitic bone, which is also now osteoradionecrotic, which is ORN. So this is how this patient will actually slough out. Basically the entire skull base will break out in bits and pieces. Sequestrated bone, and sequestrated bone becomes the nidus for infection. And this patient is certainly going to end up with a meningitis or a stroke, and he will definitely die of neural sepsis. So that is how critical it can be. So principles in overall, these cases I have highlighted, is essentially about multi-layered closure. All I need to say is make sure there is a watertight seal for the CSF leak. If the nerves are in anatomical continuity, try to preserve the nerves. Try to make sure you don't have any bleeding, because in general, this kind of skull-based surgery, you cannot leave a drain. We never leave a drain if there is a connection with the intracranial cavity or if there is a CSF leak. What is the problem if you put a drain with a CSF leak? One thing is it will suck out the CSF, isn't it? So automatically patient can develop pneumocephalus. The other thing is it can introduce infection. Patient can have meningitis. The third thing is this pressure of this negative suction will pull that multi-layered closure that you've done for the skull. Okay, so these are the reasons why you have to be absolutely meticulous in closure at the end of the day. Long day, but still this is the most important part of the surgery to prevent morbidities. You can't leave a drain in the brain. Okay, the flap. I just wanted to show you a picture of the flap, and this is a temporalis muscle, which we all know. It's a fan-shaped muscle. All you need to do is actually, this is based on the middle temporal artery. So there is a line called as the Pitanguy's line. Okay, this line is actually in the incisura of the ear. It goes right upwards. So the artery divides into two branches, posterior and anteriorly, along the fan-shaped muscle to supply the muscle. So what I wanted to highlight was, don't cut the flap here. If you cut this, the artery gets cut. Okay, so we need to rotate the flap behind like a fan and bring it down the lateral skull base and into the mastoid, but make sure that the arterial supply to the temporalis muscle is preserved. It's a very vibrant, robust flap. And in fact, you can dissect the muscle fibers further to elongate it and rotate and put it down into the neck. Okay, so that's how the anatomical picture is. But if you have larger defects, you have to get your plastic surgery colleagues to help us. So you can use a pec major, which is the workhorse, or you can actually use a trapezius or a serratus anterior or a delta pectoral flap. So these flaps can also come up to the upper end. Right. So again, I had already spoken about facial nerve. Just to reiterate the fact that if the nerve is intact, leave it alone. It do not cause any harm. But if you have a small segment of the nerve cut, connected primarily, so one-to-one closure gives you the best result. So the outcome of a facial nerve palsy is always one below what you've done. So if the nerve is in continuity, it will fully recover. If the nerve is end-to-end connected and re-anastomosed with a single stitch, then you can again get back normal grade 1. But if there is an interposition graft, you won't get a grade 1 recovery. You will always end up with a grade 2, 2.5. Okay. So if there are two suture lines across, if there is an interposition greater auricular nerve graft, then you will not get a perfect normal facial motor function. And if there is no full recovery of the facial nerve, think about alternative. Always think about rerouting the nerve. So we can do a hypoglossal or mesenteric nerve re-anastomosis, or also dynamically bring facial motor function by using slings, static or dynamic slings. This is just an example of one of my cases which I assisted when I was in my fellowship here. This is a patient with a radio recurrent extensive squamous cell carcinoma of the ear. In fact, you can see the almost 1/3 of his skull has been taken out. So he had a radical surgery. So this is a TM joint. Okay, this is the root of the zygoma, a part of the middle fossa. This is the middle fossa brain. This is the deeper aspect of the tegment. Okay, and this is the posterior fossa, squamous temporal bone. You can see a small fixture for a Baha. Okay, so this is a sigmoid sinus. The entire facial nerve has been rerouted and taken out. There is a dissection onto the upper neck for the vascular pedicle for putting in a ALT flap. Okay, there is an anterolateral thigh flap which was connected on the superior thyroid pedicle by the plastic surgeons. They came and put a flap on this. The neurosurgeons had to completely seal off the middle fossa to make sure there is no CSF leak. We had to dissect all around the temporomandibular joint and then plug the eustachian tube, so make sure there is no connection to the nasopharynx. We had to make sure there is no vascular bleed, because in this area again, after such a big operation, patient could not have a drain. So we got to be careful in the flow out. We had to keep small corrugated drain tubes on the lower end of the ALT flap to just make sure there is no collection underneath the pedicle, which can compress on the feeding pedicle of the free flap. So essentially, after this, the patient has also had a staged Vistafix, which is an artificial bone-anchored ear, okay, made of cosmetic material, prosthesis here, and then he also had a Baha to get back his hearing and balance. So he was on vestibular rehab. So interestingly, if you see this patient at the end of the day, you won't realize that he had such a big operation, and that is how meticulous they are in their setup, because they have all the infrastructure, the facilities, the professional training, the team, rehab facilities, etc. Support care is so good. So, and we are nowadays talking more about conservative approach, and that is the reason why we say navigation and high definition endoscopies have actually reduced the amount of work that skull-based surgeons do. They are more precise now, and they are more conservative in approach. So we have a minimal access routes here, and one of that is a minimally invasive retrosigmoid approach towards the CP angle. And also genetic treatment. You know, we are having some gene mutation therapies, monoclonal antibodies, which are also reducing the virulence of the tumor. So these are all the ways for the future. And hopefully, I think skull-based surgery will become more refined in the future. So take-home message from today's classes: make sure that you identify the disease properly, have a clarity of picture in discussing the situation with the patient, and also counsel them regarding the morbidities. Always make sure you have a multidisciplinary input. Call your neurosurgery, maxillofacial plastic friends, and try to preserve the anatomy as much as possible, and also prepare for the long association of rehabilitation for the patient. Work with the physio teams, following therapy, speech therapy, secure the airway, get an ophthalmologist, oculoplastic surgeon, etc., to help you out with the rehabilitation. Make sure you do a thorough job and pray for the best that the patient can survive for. If there is any disease recurrence, I'm sure there is very less options. Many of these patients will literally die because of the morbidity that they've had, and also because of aging. So overall, I think lateral skull base is a very challenging field, but it is gratifying that we can actually give an opportunity to save a life, or at least prolong a life for some time, isn't it? So thank you. So hopefully, I think this addressed most of the overview of the topics that we are going to discuss in further classes. Any questions? Feel free to ask. Just put it in the chat box. Thank you. Thank you all for the patient listening.
Raghu?
Yes, Professor Gaushankar.
Raghu, I have my questions.
Yes.
I have typed. It's in the chat box.
Okay, I think that's for everyone to see. Let me see. I think can we go from the top? I'm just going to read one by one. Okay, I think there was a good interaction from the postgraduates, and I'm sure very happy to get some positive results. I think they are listening and they are also thinking. That's the most important point of having these series of lectures. So hopefully they should have a practical approach to deal with scenarios when they actually see such patients. And that is hopefully that talk is thought-provoking for them in that reason. So somebody has asked what surgery is offered for brain metastasis. Yes, suppose there is a limited brain metastasis. Nowadays, there is something called as a metastatectomy. Okay, so you can actually use, nowadays they are using intraoperative radiotherapy also. I'm not sure if it's come to India, but I've seen that also happening. They can actually focus on the metastatic lesion in the brain, open it up, and then stereotactic guidance or gamma knife is used intraoperatively directly under the set. You can also do this as a teletherapy for radiotherapy indications. Other option is to actually excise that part of the brain which is dead along with the metastatic lesion. But if there is a situation where the lesion is near an inoperable site, like for example, there is next to a cavernous sinus or in the circle of Willis, you can't do much for it. So you have to give palliative radiotherapy. Another question, the line described by Petangi, yeah, this is very similar to the ligament of the nose. So Petangi is a facial plastic surgeon. So this line is basically to identify the middle temporal vessel which supplies the temporalis muscle for creating the temporoparietal flap. Okay, so questions, yes. Oh God, Gauri Shankar has asked so many questions. Okay. Right. Okay, I will try to answer. Fellowships and centers for skull-base surgery, very few. In fact, I was fortunate to be in one of the biggest skull-base centers in the Europe. The biggest one in UK also, in Birmingham. But in India also, I think we've got good volumes nowadays, and there are very good endoscopic skull-base surgeons. A few lateral skull-base surgeons also doing a very good job. So, in fact, the best way forward is for us to go and visit them in person, spend a few months with them to see how they approach these cases, get involved in their multidisciplinary teams, and then see how each one works, in synchrony, in coordination with each other, and how the patients managed, followed up. So surgery in itself is not the only point of learning, skull-base training. It's all about how you manage the patient, how to work up the patient, how to kind of counsel, do the surgery, rehab, etc. So basically, it's all about teamwork. In centers in India, I think Gauri Shankar can help me with that. I think there are two centers in Mumbai, one for lateral skull base with Narayan Jaishankar and one for along with Professor Morwani. There is one for endoscopic with Nishit Shah. And I think there is one SGPGI Lucknow fellowship, which is highly competitive. It's a 2-year fellowship in both anterior and lateral skull base. I also think there are, of course, Janakaram sir also is giving training in Trichy as endoscopic skull base fellowship. A few others, and in fact, I think my future dream would be to start a fellowship here in Murph, but I hope that we come through. We are still building up on the infrastructure. Slowly, we're getting a volume of case, so hopefully it will be benefit. Investment is huge. I think we should be in a multidisciplinary setup with, I think ideally corporates would be the best way to go because they have everything set up for them. Because we need people helping also around. It's not a one-man job, and it's not possible for us to handle the problems related to the surgery ourselves. So we need a neuro ICU, we need neuro navigation, you need advanced endoscopes. You need expertise, backup professional. You have to train your nurses, train the ICU staff. Everything has to be in place for us to have everything sorted for a day where you're going to work long days, long hours in a day. The role of neurosurgeon in skull-base surgery is very much equal to a ENT surgeon. So I think when I was in my fellowship, long surgeries, the theatre will be booked for a day. Minimum will be 12 hours. Maximum will be 16 hours. Sometimes it may actually go on till the midnight, etc. So we used to rotate every 4 hours. The way that the skull-base team used to work there was the neurosurgeon can do ENT part of the surgery, and the ENT surgeon should be able to do a neuro bit of the surgery. So they work like a factory. They keep rotating every 4 hours, obviously to attend a nature's call and also have a bite. And then most people do smoke also and get back to work. So they should be equally skilled. The role is equally shared between the neurosurgeon and the ENT surgeon. They should look at the skull base from different directions, but they should do the same. Exam question, I think I will discuss the exam question one by one and the different topics that we will address. There are a few questions, very nice case scenarios discussed today were also probably useful for your exams. Post-op care about follow-up, I had again mentioned that complications related to that. The rehabilitation team is vital, and the patient's mental grit willpower is very, very important. If the patient dies due to fear, he dies due to fear rather than surgery. So you don't want a feeble patient who will create a lot of trouble for us after having touched a very massive tumor. And, eventually, the management of such patients without mental determination is much more complex, isn't it? Medical legal issues, very much, yes. So that is the reason we actually are very careful in taking a high risk consent. And I had even mentioned not limited to death, because problems post surgery are more than problems before surgery. Textbooks, yes, very good textbooks are available for lateral skull base. Mario Sana's series of textbooks are there. And in fact, we have recently contributed 2 chapters to a textbook called 360 Degrees Atlas of Skull Base Surgery by Narayan Jaishankar and Narayan Prabhakaran. If you can get hold of this book, it's a wonderful book. It's a great atlas. We beautifully describe the different approaches. Really should congratulate the authors, the different authors who contributed to it. It's probably the biggest skull base book which we have currently. Theme publications. Okay. Anesthesia, a lot of anesthesia issues are there. Neuroanesthesia monitoring, we use a BRIS monitor. We also keep the anesthetist informed if there is a CSF leak to bring down the intracranial pressure, and also to do a Valsalva maneuver. Sometimes we have to put the patient in Trendelenburg position to bring down the venous congestion, venous return, bring down the dural venous sinus pressure. So those things I think a general anesthetist will not understand, isn't it? So anesthesia, neuroanesthesia itself is fellowship training, and I'm sure there is FNB, Fellowship in National Board in Neuroanesthesia nowadays, training anesthetists for neuroanesthesia, similar to transplant anesthesia, etc., cardiac anesthesia. So we should have a good, and the most important thing is anesthetists are more busy than us in the post-op care, because the patients end up in a neuro ICU and they are the ones who are monitoring the electrolytes, fluid balance, and also the lumbar tapping, central venous line, preventing urinary catheter infection, etc. etc. So we should have a good team to actually even decide to touch such patients. And unfortunately, we have one. Any other questions? Feel free to just come up and ask questions. So it will be good to sort out your doubts right away. I should really thank Professor Panipan sir from Trichy for actually participating so keenly and actively in these sessions. And today again, he was there last week as well. Thank you, sir.
Good afternoon, sir. This is Bhanumati.
Yes, sir. Please, ma'am.
Sir, some places in books we have seen suboccipital given in bracket for retrosigmoid approach. Both are same, sir.
To an extent, it is same. In fact, I also had the same confusion. So suboccipital is basically some more extending posteriorly beyond the retrosigmoid, isn't it? So retrosigmoid is the area of the temporo-occipital bone of the skull, which is behind the sigmoid. So if you restrict your bone window behind the sigmoid sinus and below the transverse sinus, it is called as the 4 by 4 centimeter window as a retrosigmoid window. Nowadays, people are even making it into a 2 into 2 centimeter window for a minimal access retrosigmoid route or a MIRA route. So if you extend the lesion, this bone craniotomy beyond that region into the occipital bone, below the nuchal prominence, if you actually palpate the nuchal line and below it, you would have to divide the paravertebral muscles in that area and go below in the suboccipital plane up to the hypoglossal. You can actually go up to the occipital condyle. So if we extend the retrosigmoid incision, which is the anterior border of the craniotomy, extend it below. In fact, we do this nowadays for ABI patient, because we need more access to depress the cerebellum. So we need to do a bone window, which is kind of retrosigmoid suboccipital. So you do a bigger window, which will go all the way up into the occipital bone. That's called as a suboccipital. Retrosigmoid is a smaller suboccipital. So essentially, both are the same.
Okay, sir. Thank you.
Yeah. There is one question on somebody asking whether we can have a live surgical demonstration. It will take me one full day. Are you ready to sit and watch that? So that is a problem with skull base, isn't it? Because dissecting takes time, and in real time, except for the person who's doing the surgery, it is boring for everyone else. So she's, I think, oh yeah, it was Satyanarayana who says yes. So please welcome. When we have the next case, I'll invite you. You can come and come to theater and watch. So of course, it is possible. Suppose if we can have a live surgical workshop where we can demonstrate. we can have this case running on in one theater, and we can have another theater showing smaller cases in between. So hopefully important parts, important steps of the dissection can be highlighted. It will be interesting because the way that we set up the patient, the positioning, the neural monitoring, anesthetic monitoring, fluid balance, how we manage intraoperative CSF pressure, those things are learning curves for all of us. In fact, it will be the best for us to learn on site, where you actually can observe how things run rather than talking in textbooks. Any other question? Sure, sir. That's exactly. In fact, I should say, Professor Pandian was very kind enough to run a lateral skull based workshop in his wonderful hospital in Trichy, so where we actually had a great day. In fact, all the important steps of lateral skull based surgery, we remember those days. That sir was kind to actually organize such a workshop. If sir can do one more workshop like that, I'm very happy to come and demonstrate. Important steps can definitely be highlighted. In fact, during one of our future talks, I will show you videos of the important steps. When we address each of the pathology, the steps are slightly different. And so we should probably see in those images. I'll show you the videos of how we go about it. Any other doubts? Any questions? Past our time, isn't it? Thanks, Gauri Shankar. I think today has been very interactive, very fruitful.
Yes, Raghu. Excellent lecture and very nice slides and CT scan pictures. And I hope it is useful for every one of you, every one of us. And PG students can make use of the opportunity, and definitely they will improve themselves. So thank you, Raghu. When is the next session?
I think next week I'm fine. I think we can, if the people are okay after Diwali, they can come back to have another academic session next Sunday. Next Sunday is fine.
Okay. Thank you very much.
Thank you. Thank you. Thank you.
Thank you, Palyapan sir, also.
Thank you, sir. Thank you so much.